I'd like to thank Professor Jorge Aliao for giving me the opportunity to speak in this session. My subject will be CAPSULaser, Selective Laser Capsulotomy, a better way to open the anterior capsule. And I have to declare an interest in this that I'm a consultant to Excellens, the company that makes the laser. So what is the problem that I believe selective laser capsulotomy can solve? And it is that we cannot deliver manually our goal for our capsulotomies in a consistent manner. That is, to create a chosen size in a perfect circle and in the desired centration. Otherwise, we end up with capsulotomies that look like this over time once the fibrosis in the capsule has taken effect. So why does this matter? Well, we know that the 360-degree coverage reduces the risk of early PCO because the lens optic is shrink-wrapped. A well-centered capsulotomy gives better IOL centration and less axial deviation and refractive change. And a capsulotomy that's too small or too large can impact on our nuclear removal. And this has been shown in many studies, some of which are highlighted here. And here we can see from these two pictures what happens when you have a lack of 360-degree coverage. On the left, there's PCO at 1 year with an asymmetric capsulotomy. On the right, where there is a capsulotomy with 360-degree coverage of the IOL at 3 years, there's no significant PCO at all. I'd like to thank David Spalton for these images. So what is out there to help us to try and achieve our goal? Well, you could use a capsulotomy ring as invented by Marie-Josée Tassignon, or a corneal marker, or you could have a microscope head-up display, or as is used with precision pulse capsulotomy, you could use the Purkinje images to center your capsulotomy, or use the apex of the anterior capsule with a femtolaser capsulotomy. Or also, you could use selective laser capsulotomy, as we'll see more of in a moment. So why use lasers at all for a capsulotomy? Well, they can make capsulotomies of a given size, which are truly circular, without the variables of the manual technique, as we've seen, in a given position, which can be useful for more complex cases, and with little risk of tear out during the capsulotomy. And also, they can be helpful, as we will see, in white cataracts. As we shall see, CAPSULaser creates a selective laser capsulotomy with a much lower capital cost than the femtosecond laser, a lower cost per case than the femto, but also precision pulse capsulotomy, with no disruption to the surgical flow, using minimal space in the operating room, and with consistent accuracy of sizing, circularity, and centration. So how does selective laser capsulotomy actually work? Well, it operates through the absorption of the orange wavelength 590 nanometers laser energy onto a trypan blue stained capsule, converting type 4 collagen to amorphous collagen. The triple helix of collagen undergoes thermal unwinding due to disruption of the hydrogen bonds, which allows shrinkage. And we can see how the structure changes from the type 4 collagen above here to the amorphous collagen below. As the collagen undergoes this phase change, it creates the capsulotomy with a rim that has a high degree of elasticity and tear strength associated with amorphous collagen. And here we can see some scanning electron microscopy examples. The edge is rolled, and you can see where we have cut through the edge on the right-hand picture that there is the amorphous collagen. This laser is continuous, not pulsed like femto. It is scanned in a single circular pattern to create the continuous curvilinear capsulotomy in under 0.3 of a second. And we can see that here. The laser beam is being centered and the capsulotomy is created very quickly. How has the laser been investigated? There were preclinical studies carried out at the Singapore National Eye Centre in the CAPSULaser labs established there. The preclinicals completed the utilization of over 2,500 porcine eyes and 150 cadaver eyes. There have also been comparisons made with manual femtocataract and CAPSULaser capsulotomies, as we'll see. We wanted to see how strong the edge was, and in a study published in the British Journal of Ophthalmology, we compared anterior capsulotomy techniques for continuous curvilinear capsulorhexis, femtosecond laser assisted capsulotomy, and selective laser capsulotomy. We were able to show that the CAPSULaser capsulotomy edge is strong and tear resistant, and when compared with flax and CCC, if CCC was considered to be 100%, flax was 70%, and CAPSULaser was 150% in terms of relative tear strength, and this was significant at P being less than 0.01. And this was a study that was used to achieve the CE mark, where we looked at the efficacy and safety of a new selective laser device to create anterior capsulotomies in cataract patients. And this was published in the Journal of Cataract and Refractive Surgery in 2019. The study consisted of 125 patients in 2 matched arms. The CAPSULaser arm had 63 eyes, the CCC arm had 62 eyes. The primary endpoint was capsulotomy precision, and we were able to show that, statistically speaking, CAPSULaser was better in terms of sizing accuracy, circularity, and centration precision compared to CCC. And this was significant in all 3 of these parameters at P was less than 0.01. There was a secondary endpoint for safety, and no adverse events were found in either of the arms of the study. We also observed that CAPSULaser capsulotomies were 100% free-floating, and also gave 100% 360-degree IOL coverage. We took the results from this study for CAPSULaser and compared them to published results for both flax and CCC for sizing, circularity, and centration. And you can see, if you look at the left-hand side of the slide, the CAPSULaser does better than both of these other 2 modalities for opening the capsule. And here we can see some typical examples of CAPSULaser capsulotomies after lens implantation with 360-degree coverage. The development of CAPSULaser has always been work in progress, so I'm now going to share with you some of the enhancements over the last couple of years. There has been enhanced microscope integration. The HD optics increase the diameter range from 4 to 5.5 millimeters in 0.1 millimeter increments. There's a better CAPSULaser mount. There's also a slide for the CAPSULaser to move it out of the way. There's now BIOM compatibility when the slide is present on the microscope. And there's also precision HD laser filters, including 532 nanometers. Let's have a look at these now in more detail. First of all, let's have a look at enhanced microscope integration. There's now compatibility with Leica and Harkstrite as well as Zeiss microscopes. There's a fully functional splash guard. There's also an objective ring cover, and also optimized laser capsulotomy algorithm to make the laser more efficient. Here we can see CAPSULaser on a Zeiss microscope, and here CAPSULaser can be seen on Harkstrite and Leica microscopes. With the optimized laser capsulotomy algorithm, we've been able to make the edge smoother and more accurate. As far as the new HD optics are concerned, they enable a large capsulotomy diameter range from 4 to 5.5 millimeters in 0.1 millimeter increments. There's minimal cortex adhesion at the capsulotomy rim compared to how it was previously, and there's less overlap region of the CAPSULaser. The CAPSULaser mount provides safe and secure attachments to Zeiss and Leica floor standing microscopes. And the benefits of this are that the console attachment minimizes CAPSULaser system space requirements. The system, the fiber optic, and the cables are all well protected. And when the microscope is moved, the CAPSULaser remains connected and mounted, and this is important. There is now a CAPSULaser slide that I stated. It has 2 positions. In the operational position, Here we can see CAPSULaser. It will be used to create the capsulotomy. There is a full field of view. However, when it's moved out of the way, it improves the surgeon's working space and also his microscope view. And this is compatible with all Zeiss, Opmi and Leica M844 and HS900 series microscopes. And there is BIOM and Resight compatibility with the CAPSULaser slide attached to the microscope, as you can see here. And this works with the Zeiss Resight 500 and 700 and also with the Oculus BIOM. The upgrade to optimal microscope visualization is achieved with new HD precision laser filters. And this leads to no visual distortion. There is full spectral definition with no discoloration and over 95% transmission with no noticeable loss. Microscope compatibility, as I say, with Zeiss, Leica and Haagstreit Mollvedel. And precision filters are available for 532, 590 and 532 plus 590 nanometers. And this year, due to modulating the way that the laser performs and its settings, it is no longer necessary to have an optical patient interface. This will reduce cost, but it will also mean that the ability to focus the laser is much enhanced, and the surgeon's view also. Now let's see what happens as we prepare the eye for the laser. And first we're going to see an intumescent cataract. This is from a video by Pavel Stodulka. The first thing that we do is to inject the microfiltered trypan blue 0.4% solution. Its specific gravity is heavier than that at aqueous, so when injected slowly it drops down onto the surface of the anterior capsule and is left there for about 30 to 60 seconds and then is carefully washed out, and it's important to do this. As you continue to do the washout, you'll see that an interesting feature becomes obvious, which is at the center of the capsule, which is also going to be coincident with the visual axis. There is enhanced staining of the capsule, and you'll be hearing more about this later on in this session. It's important now to overfill the anterior chamber with an optically clear solution of 2% sodium hyaluronate, so the chamber is nice and firm. We're now going to move on to the second stage, which is the focusing of the laser and centration. So now we can turn on the laser and the aiming beam, center it, and then fire the laser to create the capsulotomy. So the aiming beam is where the three little dots are. That's what's used for focusing. Then the circular beam is going to be centered on the area of enhanced staining. And once that's in position, you can see the capsulotomy is created in less than 0.3 of a second with no effect on this intumescent cataract whatsoever. This is again a video from Pavel Stodulka, and he's just removing the capsular cap. You can see that the soft lens matter has been kept at bay. The procedure is now at an end, and the capsulotomy is well centered with good 360-degree coverage of the IOL. And here is the latest iteration of SLC, this time using a Thornton ring to help center the beam on the enhanced trypan blue staining area. Once you've got it in position, the foot pedal is depressed and the capsulotomy created. Over 60 surgeons in many countries have now treated over 6,000 eyes in a multitude of situations. We've seen standard cataract. It's also been done on refractive lens exchange, post-RK eyes, pseudoexfoliation, glaucoma, recessed globes, detached zonules, small pupils, and as we've seen, intumescent cataracts. And here we can see two typical eyes at 18 months post-operatively. Although there has been a YAG laser posterior capsulotomy required, the anterior capsule has remained very similar to how it was when it was created at the time of cataract surgery, with good circularity and minimal contraction. So in conclusion, SLC with CAPSULaser has solved the problem of centration, circularity and size of capsulotomy. The edge of the capsulotomy has been shown to be more stretchable than either manual CCC or femtolaser capsulotomy. The capsulotomy time is now reduced to under 0.3 seconds. The long-term photos show minimal contraction of the capsulotomy edge. There is less axial IOL tilt and less refractive change because of the 360-degree coverage, and also a low cost per case and no interference in the surgical pathway. Thank you very much for your attention.